Welcome to the second webinar in the series entitled Pathways and Diagnosis. If you weren't with us on the first webinar, I'm going to repeat some crucial things that we went over in order to understand what this webinar series is going to be about. The idea behind these webinars is I want to try to teach you a rubric that you can bring back to your practices and how to take OCT to the highest level. How can we use OCT to its best ability in helping us to diagnose and manage patients with various conditions, various eye conditions? So the first webinar talked about AMD. This webinar we're going to go into diabetic retinopathy. So we want you to use what you have to its maximum potential in both early diagnosis, management, and treatment of these patients. So before we begin the webinar, it's important to understand that diabetes affects almost 25 million Americans today, and almost 40% of those have retinopathy of some sort. So we're a huge part of this game on taking care of these diabetic patients, because almost every patient that walks into our office is really somebody that may have the disease. So if you don't have an OCT, it may be something that you want to consider purchasing, because this is a very, very highly common disorder. So the question is, how can we use spectral domain OCT to help us both diagnose and manage patients with diabetic retinopathy? Okay, it's not the take home, it's not the only thing that we need. It doesn't replace the normal exam that we do, but we want to be able to incorporate it into our practices to make us better doctors. We're going to use the information that, let's say, our technician provides for us, and we're going to get preemptive or early information on our patients before we even see them, okay? We're going to use retinal thickness maps that the OCT provides. We're going to use the ganglion cell maps that the OCT provides, and we're going to move forward with all this information to help us be better doctors. So this slide I'm putting on all the webinars because, again, I want to go through what the OCT is, how to interpret the scans so you understand what normal versus abnormal looks like, okay? So on the right side, you can see what the printout of the OCT looks like. We all know that it's a non-invasive test. Anybody can do it. The technician can do it. We seat the patient behind the camera, and it takes multiple images in seconds. It uses light waves to provide us with a tomographic or cross-sectional image of the retina. And this is what a printout would look like in the most common sense. There's many printouts. And I'm going to go through pretty quickly here what the OCT printout encompasses. So the black space on top is our vitreous body. We have our inner retinal tissue, which is made up of the ganglion cell complex, the inner plexiform layer, and the internuclear layer. That's the hyperreflective layer on top of the scan. We have our outer plexiform layer and our outer nuclear layer, which make up our outer retina. We have our external limiting membrane. We have the IS-OS junction, which is the inner segment, outer segment junction of our photoreceptors. Then we have the retinal pigment epithelium, which is the hyperreflective red line. And then we have our choroid. And it's very important when you're looking at various disease processes to understand what part of the retina that disease process affects. Diabetes in particular affects inner retinal tissue. So we're going to emphasize throughout this presentation that we're going to mostly be looking at the top of the scan, because most times, unless there's a huge amount of macular edema, we're primarily looking at that inner retinal tissue. If you look at the bottom picture, what I've done there is kind of showed you how each area on the OCT correlates with a histological sample of the retina. So you can compare in your mind what you know is going on histologically to what you're scanning on the retina. So if you can't remember what this looks like, or you have trouble remembering the layers, you should have a picture of this up in your office that you can refer back to. That way, if you see an irregularity on the scan, you can say, oh, that was in the outer retina, or that was at the RPE. And you can always refer back. So again, here would be the scan and the area of emphasis. Diabetes is primarily an arterial disease. Arterial diseases primarily affect inner retinal tissue. Okay, so this is something to keep in mind. So this rubric, which I started in webinar 1, and I'm going to go through all the way through webinar 6, is that we want to use our technicians to the highest level. We want to train our technicians to ask the appropriate questions in the patient's history that will help us to get everything we need from them. So a patient's history with diabetes is going to look very different than a patient's history with glaucoma or macular degeneration. And your technician needs to have a spreadsheet or a cheat sheet, if you want to say, on exactly what we're looking at. because if they don't get the important questions, we would need to go back, and we can go back and obtain those questions. So here's a little outline or flow sheet of the things that I think are most important when we're working up these patients. The most important thing, obviously, in any patient, regardless of diabetes or not, is why are they there? Are they having new complaints? What is their symptomatology? Okay? Are they having a new onset of fluctuating or blurry vision? And I would say that that's probably the most common complaint that I see in my diabetic patients, that as their blood sugar fluctuates, their vision fluctuates. Okay, so it's not enough to just say you're having blurry vision. Well, is the blurry vision fluctuating? Do you notice that some days when your blood sugar is better, you're seeing different than on a day when your blood sugar is spiking? Okay? Are they getting floaters, recent onset floaters or spots, which may indicate that there's something going on in the vitreous? It might be a vitreous hemorrhage, might be some spots of blood. Okay? What about dark spots in their vision? Again, may indicate macular edema. Are they getting almost like a scotoma of some sort, some fluid there? Okay, so these types of questions can help to direct us towards what we're going to see when we actually look at the fundus exam. What about their medications? In every disease state, medications are crucial because some medications affect the macula, other medications have side effects that can affect systemic conditions. Okay, so the first thing would be cardiovascular meds, and in specific, the statins like lovastatin, thiazides, hydrochlorothiazide, beta blockers, atenolol. Okay? These classes of medications are known to increase insulin resistance. It makes it much harder for the patient's body to utilize circulating insulin when they're on these medications. So these medications can actually make a patient's situation worse for them when all they're trying to do is manage other conditions. Okay, so that's why it's so important to find out what they're taking. It's not enough for them to tell you, well, I'm taking something for my high blood pressure. What are you taking? And if they don't know, attempt to get that from their primary doctor, from their internist, so that you can co-manage the patient to your optimum potential. This is very important in diabetes, that you're familiar with the levels, okay? What's the normal fasting blood sugar level? If you were to take a patient at one moment in time, after they fasted and you send them in for blood work, what should you get? It should be 70 to 100. Okay, so somebody that hasn't eaten for a while, that's the number we want. What about a random point during the day? Okay, what if they hadn't fasted and we went and we sent them in for blood work? We want it to be less than 125. Okay, but really the most important number in diabetes is the hemoglobin A1C. The hemoglobin A1C gives us a 3-month estimate on how the patient's been doing with their blood sugar over time. Okay, so if Mr. Jones had a bad week in June, but he did great in August and great in September, hopefully his HbA1c is going to show us that. Whereas if we would have done a random blood glucose on a day when he wasn't doing very well, he would have had an elevated blood sugar. Okay, so the normal HbA1c is 4 to 5.6. A patient at risk, and I don't like to call it pre-diabetes, but a patient that's at risk for developing diabetes would be somewhere from 5.7 to 6.4. And diabetes itself, greater than 6.5. We like to keep our diabetic patients under 7. Okay, I still like it more under 6.5, but that's what we want it to be. Okay, does the patient have a glucometer? Do they take onus and measure their blood sugar at home on their own? Okay, so these are all really important questions to ask. Most patients, at least in my clinic, don't know what their blood sugar is. Okay, they come in, oh, it's been good, they don't know what it is. Okay, so if you can work together with the patient's internist to get this information, it really helps with the exam. Risk factors. Every disease process has risk factors, okay? In diabetes, the risk factors are things like obesity. A BMI greater than 25 puts a patient at risk for diabetes. High blood pressure, greater than 140/90. And those are controllable risk factors. Those are things that we can say to the patient, lose weight or work better with your doctor to control your blood pressure, do more exercise. But there are certain conditions like how you were born, what ethnicity you are, that you can't control. Okay, so if you're a Mexican or you're an Eskimo, those ethnicities, Asians, blacks, have a higher tendency to get the disease than some other subtypes, some other groups. So that one you can't control, but that is a risk factor. After the technician has obtained an excellent personal history, we have them move on to family history. And again, family history is a big deal with diabetes, okay? Patients that are type 2 diabetics that have a parent, one parent with diabetes, or let's just say individuals that have one parent with diabetes have a 40% chance of getting the disease. Individuals that have both parents have a 70% chance of getting the disease. Okay, so there's a very large correlation in families. And the question always is why? You know, do we share genes? Well, we certainly share genes, okay, that might make us more prone to it. Okay, that would be the easy answer. But what else do families share? Why is it that families that have the disease are more prone to getting the disease and keeping the disease in the family? It has to do with what we do, what they share. They share habits, they share eating habits, they share exercise habits, okay? Certain families like to eat fried food, certain families exercise more. So kids watch their parents, they mimic what their parents do. All right, so we tend to see habits repeated themselves in families, okay? So once we've obtained the history to the best of our ability, or once the technician has gained as much information as he or she can, we move on to get our screening OCT. Okay? And I emphasized in webinar 1, and I'll emphasize again here, I don't care, it doesn't matter which instrument you use, but the idea here is that there are certain parts of the OCT that we want to look at preemptively. Okay, we want to have some assessment of retinal thickness tissue, or the thickness of the retinal tissue, the ganglion cell complex, and how this patient compares to the normative population. So I mentioned before that I like the OptiView Eye Wellness Scan because it gives us everything on one printout that we want to see preemptively. You can use the Cirrus, you can use Heidelberg, anything you want, as long as you get all of the information on the scan that you want to get. So the question is, what are we going to uncover about this patient before we even see them? Okay, so I'm going to run through quickly how to interpret the scan, because once you understand how to interpret the scan, you can look at any instrument and understand how to look at the scans. So the top part of the scan is your B-scan interpretation, which is your cross-sectional image of the retina. And you can see here that there's a little abnormality on one section of the B-scan. You can see that little hyperreflective spot, which if we're looking at a diabetic, we can make the assumption it's an exudate. Exudate occurs in the outer plexiform layer, which is really, it's not the best scan, but that's where that would be. If you weren't sure what it was, we're going to go ahead later on and do much more specialized testing to try to hone in on the abnormal area. But you can clearly see there's something going on here. You can see on the retinal thickness map on that left eye, we talked in the first webinar about how the retinal thickness map is measured in microns on a micron scale. Green would be normal thickness. So when you see a patch of red like that, that's indicating there's some thickening or significant swelling associated with that area on the B-scan of exudation. Okay? And what's really interesting is that if you were to just look at that B-scan, I don't know that you'd be able to tell how much swelling is actually associated with that exudate. But that retinal thickness map is pointing out to you that there is quite a bit of fluid in that area. The last part of the printout is the ganglion cell complex. And this, again, if you missed the first webinar, again, the ganglion cell complex should image like a green donut, like the right-hand eye there, the right eye. The black in the center is the fovea, which has no ganglion cells, so it's black. And then the greatest concentration of ganglion cells is around the fovea, so that should be nice green like that. In the left-hand side, or the left eye, you can see what an abnormal ganglion cell complex would look like. You see the black fovea, you can see the beginning of the green donut, but then you can see that big hot spot, that big red hot spot, which is correlating to that area of thickness, which is correlating to the area of retinal exudation. Okay? Why is the ganglion cell affected, or the ganglion cell complex affected in diabetes? We all know, I mentioned before, diabetes is a disease that affects the inner retinal tissue. It's an arterial-based disease. So the ganglion cell complex is made up of the inner retinal tissues, the nerve fiber layer, the ganglion cell layer, and the inner plexiform layer. So if those layers are affected, which they are in diabetes, the ganglion cell map is going to be abnormal. Okay? So it's important, again, to understand how each disease process works and the pathophysiology so that you can understand how the OCT is going to be affected. So when you look back at the overall map, what does the ganglion cell map and what does the overall map tell us? That the patient has some sort of retinal disease. Okay? When you compare the eyes, you can look number by number at the GCC, and you can see how not only did the eyes differ, you can do an inter-eye comparison number by number, but you can also see how the inferior and superior parts of that left eye compare, because the inferior part is not affected and the superior part is. And that's actually important, because if you were to go back 3 or 4 months out and look at the GCC again, or didn't do another eye wellness scan, you can compare how the patient was at this point in time versus how they are then based on the numbers on the GCC scale. So once your technician has gotten you all that information, you're going to get some non-dilated photos, and you're going to stack the non-dilated photos with your screening OCT. Okay, so here you can see the technician has given you photos of the patient, and you can see that that right eye looks fine. Okay, that's what we would expect, at least based on that eye wellness scan. And then you can look at your left eye, and you can see that the patient has exudates there, clearly highlighted, that correlate with that area in the OCT. And I said before, is it just exudate? Because if I were to look at that picture in clinic, I wouldn't say with confidence, or I would say I don't see any swelling. All I see there is exudate. The OCT highlights those swelling or the amount of edema in that area. And it may even lead you down the track of saying, is there diabetic macular edema? Okay, is this affecting the fovea? Okay, now it's your turn to sit down at the slit lamp and take over the exam, and again start to put together the puzzle pieces that your technician has provided you with. So on the slit lamp exam, what's important in diabetes? There's quite a few things, right? We want to start off with intraocular pressure, because if a patient has proliferative disease, their pressure may be high if it's affecting the iris or the angle. So getting a really good pressure reading is very important. Looking at the angle, is it narrow? Has there been trauma? And we can use gonioscopy, obviously, to look at the angle. Super important to do gonioscopy to look for any neovascularization of the angle or of the iris. But we can also incorporate the OCT in here. We can do an anterior chamber OCT, and we can measure the angle using a little line, using a graph or a scale or a ruler. Okay? And you can see here on this picture of the anterior chamber OCT that angle measures greater than 20. You can see the corneal endothelium, and you can see the bumpy ciliary body band, and the area in the middle is your angle. So if you take a ruler and measure that, you want it to be above 20 degrees, at least on the OptiView, and that would mean that the angle is open. Okay? So you can incorporate the OCT into the rubric. Remember that the OCT is not going to show you NVA, so you have to still do gonioscopy. It can't take the place of gonioscopy. Okay? And then obviously the rest of the anterior segment evaluation, inspecting the iris, looking at if there's any cataract. Remember that in diabetes, they're in diabetics, cataracts form earlier. Okay? They get specific types of cataracts, and they get them earlier than patients in the regular population. All right, so now that we have our slit lamp exam out of the way, we're going to sit down and we're going to start to hone in on more specific tests using the OCT. And I'm going to go through a myriad of examples here of ways that the OCT can pick up on pathology that you might not have picked up on clinically. So we start off with what we call our 3D optic nerve head scan. And students say to me, why are we doing an optic nerve head scan on a diabetic patient? Well, I'm going to go through examples of why it's so important to do a 3D optic nerve head scan. Remember that the 3D optic nerve head is going to show you elevations and depressions in the peripapillary space. The normal optic nerve head should have that dip or that divot that you see. But what about situations where the nerve is abnormal? Okay? Do we lose that divot? What happens in that peripapillary space? So here you can see an example of a situation in a patient that has proliferative diabetic retinopathy. They have NVD. And when you look at the photo, you can clearly see the NVD. Okay? What would that look like on an OCT of the optic nerve head? Well, you can first off see that divot that I talked about is missing. And the reason it's missing is because there's that superficial fibrovascular membrane there that's extending from the inner limiting membrane anterior into the vitreous. That's substantiating or confirming the presence of NVD on this nerve. Okay, so here's a case where maybe you didn't know, were they collaterals, are they deeper vessels? Here the OCT would confirm that they're actually superficial vessels and they're NVD. Here's another example of proliferative diabetic retinopathy. The top scan is neovascularization elsewhere. You can see how that hyperreflective tissue is extending anterior up into the vitreous. That's a fibrovascular growth extending off the ILM. And then your 3D nerve scan, which I'm showing on the bottom right here, again in a patient that has NVD. This patient, you can see the nice contour of that nerve that we talked about, but you can also see that there's an abnormal lip of tissue, that big fibrovascular shield or scaffold that is forming from the neo. So this case may actually be more advanced than the previous case because this one's beginning to form a full scaffolding of tissue, meaning that there's been some fibrosis. Here's a patient that has proliferative diabetic retinopathy, NVE and NVD at the same time. The case on the left, or the picture on the left, shows you the NVE. Again, you can see the fibrovascular growth extending forward and anterior into the vitreous. And you can see the NVD on the right-hand side. You can still see the nice dip in the optic nerve, but you can see the scaffolding that's coming up and extending anterior into the vitreous space. Okay? So those examples that I just showed you are exactly why you need to incorporate the 3D optic nerve head into your diabetic scans. Because any time that there is a possibility that the optic nerve may be affected, you have to run it. What about a vitreous hemorrhage coming off of the nerve for a second? What would that look like? A vitreous hemorrhage blocks all light from getting down into the substance of the retina. So when you do an OCT on an eye that has a large vitreous hemorrhage, you're going to catch light initially, and then everything underneath it is blocked. Okay, so this is what happens in an eye that has vitreous hemorrhage. OCT is not particularly useful unless the vitreous hemorrhage is not dense in patients that have vitreous hemorrhage because of this reason. Because the optical shadow and because the signal is blocked by the bleeding. Here's a case where there's a vitreous hemorrhage that you can actually see through. It's not as dense. Okay, so in this particular case, you can see that there's pigment in the vitreous, pigment pieces scattered around, but you can actually get through enough of the retina to see that there's cystic edema going on, that there's also non-proliferative changes apparent there. So in this particular case, the OCT actually helped us because we were able to see past the vitreous hemorrhage into the substance of the retina. Okay, so going back now to the scans, we started off with 3D optic nerve head. What about the nerve fiber layer? Okay, so the first question the students might say to me is, why are we doing 3D nerve? But then they'll say to me, why are we doing RNFL? Okay. And RNFL is done because RNFL can give us great information about the peripapillary space. You may have a patient that has almost no retinopathy and have a loss of nerve fiber layer, or vice versa. You may have a patient that has a ton of retinopathy and a healthy nerve fiber layer. Okay? So here's a patient that may have, let's say, moderate NPDR, the one I'm showing you here, and there's two different scenarios. Maybe the RNFL is normal, maybe the RNFL is affected. Okay, and the idea here again is that diabetes affects the entire retina. It can lead to ischemia of the entire retina. So we want to assess all of the tissue. The GCC is a big topic now in diabetes. The reason is there have been multiple reports or multiple pieces of literature written about the correlation in type 1, especially diabetics, and the GCC, in the sense that they believe that diabetes might have a neurodegenerative effect on the retina. So if diabetes has a neurodegenerative effect on the retina, the ganglion cell complex is going to be affected or compromised, even if the vascular component is missing. So if you see this patient here, this photo, the patient has minimal diabetic retinopathy. But look at their GCC, look at their GCC photo. It's red. It's completely abnormal. You can see there's an absence of that nice green donut that we see. It's completely irregular. So the question becomes why? If the retina looks like that, why does the GCC look like that? And again, the thought process is that diabetes affects the retina in a neurodegenerative way, and that, in a sense, would affect the ganglion cell complex. Okay? So very important here, in this patient, they're not as clean as you think they might be. They have significant intraretinal damage going on that you can't see just by looking at fundus exam. Okay, so that was the GCC, the RNFL, and the OCT, and the optic nerve head. Now we're going to move on to the retinal analysis. We're going to get the specific images of our retina that we want to hone in on. In this image here, I'm going to emphasize the importance of evaluating all the retinal cuts when you're doing OCT. Okay, here's a patient, same eye, one cut on the left, one cut on the right. Okay, when you look at the cut on the left, the patient looks pretty clean, no evidence of macular edema. What happens when you move that scan? When you move that scan, you can now see that the patient has macular edema. You would have missed that if you were only looking at one slice in time. Okay, so emphasize the importance when you're doing a grid scan or any high-level scan on the OCT that you don't sit down and just interpret one image. You need to move the scan. It's a dynamic technology. Looking at this image here, what else can these eye wellness scans, and we mentioned this much earlier, is there diabetic macular edema? And this is something that we're going to hone in on when we get these specialized scans. Okay. What else can the OCT provide us with? What other specialized testing? It can give us a trend analysis, okay? Looking at change over time. In every single segment of the printout, it can show us the thickness map, how it's changed over time. It could show us on a significance map, is that area still deviating from normal? It can show us on the significance map on a micron scale, is it deviating out of normal? And then obviously the B scans, looking section by section. Is the patient's maculopathy getting worse? Okay? This is a very nice example of the trend analysis or change analysis in an abnormal patient. Here's a patient that we saw that had a significant amount of macular edema. So when you look at the top left photo, you can see that red or the white, which means that the patient is outside that statistical norm. The micron scale is way above. It's in that warm colors, indicating a lot of swelling. Okay? You can see the ETDRS map, which shows us, again, the statistical significance way outside normal limits. So here's a great example of how we can use the trend analysis. This was a patient that had significant diabetic macular edema. You can see it on the B scans on the bottom, and you can see how it correlates with that thickness map on top. There's just a tremendous amount of thickening. The red-white scale means that we're totally off of the micron scale. This was a patient that we sent for treatment, and they came back after, and we repeated the scan. Here we have, this is an indication, this is the trend analysis. You can see on the right-hand side, number one, how the B scan looks significantly better, okay? Almost no macular edema left. And look how that thickness map has changed. It almost went back to normal. There's still a little bit of blue in the center of the scan, which correlates with some atrophy of the tissue from the damage that happens. But overall, you can see there's a tremendous change in that patient's macular thickness or retinal thickness. You can see how that ETDRS map went back to almost normal. Again, that red in the middle is showing there's a statistical significance of abnormality in the center because of the atrophy or the damage that happened. But this is a really nice example of a change analysis in a patient that we sent for some treatment. I introduced this concept in the last presentation, the en-face concept. If you think about slicing a steak down the middle into sections, that's what the B scan essentially does. It gives you cross-sectional slices through the retina. What the en-face characteristic does is it gives you a fillet image. If you were to stand on top of, let's say, a slice of meat or something, and you were to peel off layer by layer, that's what the en-face does. And it's an excellent tool because sometimes it gives us information about what's happening all the way from the bottom coming up. Okay, so you can look at this image on the bottom and you can see that en-face can be done all the way from anterior, let's say vitreous, all the way down to choroid. And it gives you a different dimension in your scans. Okay, so let's look at an example of how we can use en-face in a diabetic patient. Here's a patient We're standing on top of the retina, okay? We can see here that the patient has exudation and hemorrhaging on the photo, okay? What if we wanted to see if there was anything else going on subretinally? Okay, what if we were concerned maybe that there was NVD or NVE and we wanted to look into the vitreous? We can look layer by layer. So the first cut on the top left is your ILM, your inner limiting membrane, which is your most superficial layer, and it looks normal. You can see the blood vessel flow, you can see everything looks fine. If you look into your IPL or your plexiform layers, you can begin to see that image, that abnormal half moon shaped image on the top of the photo, which correlates with the exudates that you see on the photo. And that actually makes sense because our exudates we would expect to be in our outer plexiform layer. So when you look at the cut correlates perfectly with the fundus image. Then we go down to the RPE. The RPE looks normal and the choroidal vasculature looks normal. So in this particular case, there was nothing else going on in the patient, but it substantiated where the area of damage was or was occurring. In the image on the bottom, I'm showing a proliferative case, okay? So proliferative disease shows up beautifully on FOSS because you're looking superficial into the vitreous. And here you can see on your most superficial cut at the level of your ILM, you can see that abnormal vasculature permeating off of the disc. So it's really a nice feature that you can use if you're not sure either how superficial or how deep a defect is. Then you take all the information that you've gotten and you sum it up. You look at the symmetry between the eyes. And I stress the symmetry because in a patient that has diabetes, you would expect the retinopathy to be symmetric, okay? A patient that has a systemic disease should have symmetry between the eyes. If there isn't symmetry, you need to start investigating the reasons why. Perhaps there's a carotid artery problem. Perhaps it's not a systemic condition. Maybe it's something that mimics a systemic condition, okay? So we look at each part of the photo. We look at the nerves, we look at the macula, and we look overall at the pole. And we want to assess, again, the symmetry of the condition, okay? And here's the rubric, again, that I presented. We start off with the patient's personal history. We go over their medications. Okay, we go over any new symptomatology that they may be having. We go over the family history because it's a very strong tie in family history with diabetes. We do our screening OCT. In this case, we picked up on some exudate that actually had more thickening or more swelling than we would have anticipated. We get the non-dilated images and compare them to the OCT images. We get our slit lamp exam looking for any signs of proliferative disease. We can even incorporate, again, the OCT into that, looking at the angle if we wanted to. Then we hone in on our OCT on the more specialized testing that we want. We take the areas of abnormality that we found on our screening exam and we run more specialized testing. And then we do our dilated exam, really looking for symmetry, looking for anything that might stick out as abnormal. And then we take all of our information and we make a management plan for the patient. Let's look at a case example of a diabetic patient that I saw in my clinic and go through what we would do. Here we have a 56-year-old Caucasian male. He's got 20/20 vision. He's not complaining of anything, okay? And when you look at his fundus exam, he may have a blood heme here or there. But overall, it's pretty unremarkable. Then we went and we ran a screening OCT. We ran the eye wellness exam. And what did we find? We found a little pocket of edema in that inner retinal space that I surely could not see just on fundus exam, okay? This is gonna prompt me or help me move in the direction now of getting more testing to make sure that this patient doesn't have anything else going on that maybe we don't see fundoscopically. And you can see on this image here, the GCC is not perfectly normal because that inner retinal tissue is not perfectly normal, okay? Here we got a higher definition scan, and you can clearly see that the patient has clinically significant macular edema. They have a pocket of fluid right at that foveal space that may or may not have correlated with how well you can see fundoscopically. So this is a perfect example of a case where the OCT saved us in the clinic because the patient was referred out in a very timely manner for intervention, whereas we might have sat with this patient longer if we didn't have the scan. Was there what about this patient? Different patient. You look at the fundus image, you can see it on the left-hand side and then the fluorescein on the right-hand side, or the black and white. I wasn't impressed that there was too much going on, and it was a pretty good image in. But then we went and we got an OCT, and they had whopping cystoid macular edema, or clinically significant macular edema. So here's a patient, again, that was saved by us doing OCT, and this one was pretty significant. This shouldn't have been missed fundoscopically, but wasn't all that obvious until the OCT was done. Let's look at another example. Here's a 54-year-old white female. Okay, she's been diabetic for 16 years, type 2 diabetic, and hypertensive for 14. Okay, so she's got that hypertensive risk factor. Remember, we talked about the hypertensive medications, the beta blockers, the thiazides, the ones that we worry, the lisinoprils, okay, the things that we worry about, the ACE inhibitors. She tells me she's on lisinopril. Okay, so automatically, that's a risk factor because that medication is going to disrupt her insulin use. Okay, so that should kind of be a red herring. She tells you there that her blood sugar is 140. Remember that it should be around 125 if we're taking a random blood sugar. And she has an unknown A1C. They don't know what it is. Her blood pressure was 150/78. We want it to be below 140. Okay, so she's got a lot of stuff going on here. Look at her weight, 300 pounds, and she's 5'9". So her BMI is 44.3. Remember, we're a risk factor. We want the BMI to be less than 25. Her visual acuity is decreased in both eyes, more so in her left than in her right, 20/30, 2100. So overall, we have a very poor clinical picture here just as far as risk factors go. Okay, and here I've highlighted those elements. We get the screening OCT. What will we see before seeing the patient? Well, we can clearly see in that right eye, this is the right eye, that the patient has exudate, thickening, swelling. Okay, may not be able to tell if it's clinically significant macular edema, but she clearly has thickening going on there. Look at the thickness scale. It's in those warm colors. Okay, it's not that nice green that we want to see. You can see on the statistical significance map that the colors are high, meaning they're statistically outside normal limits. Look at our left eye. Similar, might even be worse. Some very big patches of red and orange there, correlating with that exudation and cystic changes in the macula. We get some fundus photos. We compare the fundus photos to the OCT. You can clearly see on the fundus photos that the patient has a lot of exudate. Okay, again, you might not be able to tell just by looking at those fundus photos the amount of edema that this patient had. We can tell there's maculopathy, but that OCT is going to confirm for us that there's actually clinically significant macular edema. We get some more specialized tests and we run a nice printout on this patient. We can see that thickness map again. We can see the significance maps in our B scans. The map on the bottom shows us just how elevated and just how close that thickening is to the cross section, which is your fovea. And this is your left eye, same thing. This one's even more elevated and more red into those warm colors than the right eye. What about the change analysis that we've talked about so many times? We look at the initial scan, which is on the bottom of the image, and the follow-up scans. Has there been any change? It looks like on the follow-up, her exudates are now closer to fixation, at least in that right eye. Okay, so this might be a patient that initially never made it to the retina specialist and then came back, and now you can see that things have essentially gotten worse. Okay, the area of change has migrated closer to the macula. So you can precisely identify exactly where the problems are going on with this OCT change analysis. So the summation, the risk factors that we talked about, the BMI, the hypertension, the possible medications, the poor control, the abnormal screening exam, the abnormal specialty exams or higher end exams, the abnormal fundus appearance, and then obviously the evidence of the macular edema bilaterally. What do you do for this patient? We have to send them out. There's a lot of people involved in this. The internist or the primary care doctor needs to be aware that this patient's blood sugar control is terrible, or maybe it's not terrible, but it's not ideal, okay? She's obese. We need to talk to her about lifestyle changes, okay, to help to improve her overall prognosis with the disease. We need to refer the patient for retinal intervention, okay? And like I said in previous webinar, I like to bring these patients back in a month to make sure they're not lost to follow-up and to see how she's doing. And I even like to show them the OCTs. And I show them all the areas that look abnormal, and I show them a normal. Sometimes it alarms them to see how different their eye looks from the norm, or even a fundus photo, because sometimes the red, the blood, is more significant than showing them what an OCT looks like. So again, this presentation hopefully helped you to understand or to incorporate how to use the OCT to its maximum potential in your practice, and it showed you examples of where we were able to pick up on things that we may not have seen clinically in the exam. Thank you.